reporting live from Dr. Soloway's studio. Nah, I'm kidding. It's not the mobile office. It's not the real office. It's the kitchen. So I'm reporting to you tonight from the kitchen. And tonight's topic is ankylosing spondylitis. You people out there have inspired me to wonder a lot about ankylosing spondylitis. Personally, I believe ankylosing spondylitis is more common than rheumatoid arthritis. Muhammad Azad Khan agrees with me. Dr. Khan is about 85 years old, semi-retired. I believe he's at the Cleveland Clinic. Once you learn how to read your own sacroiliac joint x-rays, you find out very quickly that ankylosing spondylitis is by far and away more common than rheumatoid arthritis. I couldn't even tell you how much more, because there's no data to support what I'm saying, but considering I've seen more patients than anybody practicing in the United States, I would say that my fund of knowledge, or experience at least, would be high. My fund of knowledge is debatable. I might not know anything, but if you really thought I was dumb, you wouldn't be watching me. But then again, I'm trying to make you laugh too. So, for what it's worth, ankylosing spondylitis falls under a heading called spondyloarthropathy. Spondyle refers to spine, and arthropathy simply means arthritis, or joint inflammation. So rheumatoid arthritis, as I've taught you, is a small joint symmetric arthritis. I like to tell the patients that when they're in the office and I've made this diagnosis, they say, well, what is this? I've never heard of this. So first I tell them that rheumatoid arthritis is an inflammatory disease under the heading of connective tissue diseases with lupus and Sjogren's and myositis and scleroderma. Ankylosing spondylitis, on the other hand, is also an inflammatory disease, except it's under the heading of spondyloarthropathies, accompanied by its teammates, psoriatic arthritis, the inflammatory bowel disease arthritis, or the arthritis of Crohn's or ulcerative colitis, the axial manifestation of celiac disease. Did you know 20% of celiac patients will present with bilateral sacroiliitis? And there are some rarities, although sarcoid is not so rare. In fact, I refer to it, along with the people that taught me, and by the way, I was taught from brilliant people. Dr. Hoffman is out there, he's brilliant. Ralph Schumacher, legendary, the Babe Ruth of rheumatology. So, God, my phone just went off and distracted me. But the spondyloarthropathy class includes all those things. Sarcoidosis is another one. They call it the fifth spondyloarthropathy because so many people have it, and a large percentage of people, 10-20% of them, will actually show up with sacroiliac disease prior to getting the lung disease. Now, you should know that ankylosing spondylitis is associated with other things. So an ankylosing spondylitis patient can get apical bullous lung disease. Well, what on earth is that? Well, long story short, it's a chronic lung condition from an association with ankylosing spondylitis. In addition, the ankylosing spondylitic diseases can be associated with hidradenitis suppurativa, or inverted or acne inversa, pyoderma gangrenosum, erythema nodosum, psoriasis. There's more. This is all ad lib, so I don't have an encyclopedic list in front of me. That's where the question and answer form comes in handy. But the hallmark: spinal involvement, buttock involvement, mid-back involvement with morning stiffness. Now, the rule book says an hour of morning stiffness. Well, a dumb guy once told me rules are for fools, but that was the smartest thing the dumb guy ever told me. Because the guy who writes the rules, he's writing them based on research criteria, and they do this to get grant money. So the guidelines are not made for diagnosis of a disease. So you might say, Jesus, this is really confusing. And by the way, this applies for all diseases in rheumatology. Whenever there's guidelines, it really means things are subject to the user, to the doctor, to the discretion of the doctor, his history taking, his physical exam, and the exclusion of other known diseases. So if you have granulomas, which are a pathologic finding, it's not ankylosing spondylitis unless there's two diseases. If you have rheumatoid nodules, it's not ankylosing spondylitis. It may not be rheumatoid arthritis, but it's certainly not ankylosing spondylitis. So what about the SED rate and the CRP? Well, those are acute phase reactants, and they're very nonspecific. In fact, they're very sensitive. If you sneeze, they rise up, and if you don't sneeze, they go down. If you go to the bathroom, they go up. If you have a heart attack or a stroke, they go up. So they're not specific enough, really, to use for anything, except maybe in giant cell arteritis or polymyalgia, where patients have a stroke, they can't talk, and the only thing you have to follow is the numbers, because we don't treat numbers, we treat people, and we don't diagnose by criteria. We use the criteria as a guideline, but we don't follow as a hard, fast rule. If your doctor is following a hard, fast rule, then you've got a doctor that's not that good. You need somebody that understands the topic and can put it all together for you. So the way I explain ankylosing spondylitis to my patient population when I give them this diagnosis, I explain to them in a simplistic fashion that it's essentially rheumatoid arthritis of the ass bone. What's the ass bone? The sacroiliac joints. So if you've got bilateral sacroiliac joint abnormalities and you're under 45 years old and you wake up with morning stiffness in the spine and the butt, you probably have ankylosing spondylitis. What does your doctor need to do? Needs to measure your lumbar spine, both standing and then bending, and see if there's a restriction of lumbar flexion. Needs to measure with a tape measure your breathing in and out to see how far can you expand the tape measure. If you can't expand it, then you've got rib involvement and cartilage involvement of the rib. So the other word, enthesis or enthesopathy, applies in this disease, but not in rheumatoid or lupus or scleroderma, but in the spondyloarthropathy group, which includes ankylosing spondylitis, which is the Cadillac of this group, followed by psoriasis, Crohn's, ulcerative colitis, sarcoid, and then rarities, which I was alluding to before, but Behçet's disease can involve the sacroiliac joints. If you have unilateral or one-sided involvement, you must never overlook the possibility of a chronic infection. Tuberculosis or a drug addict shooting with needles will get involvement of an infection in one joint. And there are other situations. The treatment for this class of diseases is generally TNF inhibitors, which is similar to rheumatoid arthritis. There are some exceptions, but I personally think that the infusion as opposed to the sub-Q is better. I think there's better absorption. There's forced compliance if it's given at the office. And frankly, just so you know, receiving the infusion in the office is cheaper than receiving it at the ambulatory care center, cheaper than the oncology clinic, cheaper than the hospital. How much cheaper? 50%. Wow, doc, 50%. How do you do it so much less? Well, I'm just a regular old office. I can't justify ripping off the government, and Lord knows they audit you every day. So we help you, we help them, we save everybody money, and we make everybody better. If you have any questions about this topic, I hope you call me, I hope you write me, hope you do something. You should read my book. It's available at the office. It's also available on Amazon.com, BarnesandNobles.com, and other outlets. I believe if you go to the website, www.badmedicine.net, it'll bring you to a place you can get the book. I'm happy to sign all books. Happy to have you people watching me. And Merry Christmas, Happy New Year, Kwanzaa, Thanksgiving, Old Saints Day, whatever you want it to be. Have a great day.